Basically, disease relapse of AML after allotransplant is the single most important cause of treatment failure. Even though we have non-relapse mortality and other causes of treatment failure, but relapse of the primary disease, relapse of AML, is the most frequent cause of treatment failure, and relapsed AML after allotransplant has a dismal prognosis. However, recent years have witnessed significant changes in the characteristics of patients undergoing allotransplant, and new strategies for the management of post-transplant AML relapse have become available, including the use of targeted therapies, for example, the use of FLT3 inhibitors for FLT3 ITD AML, as well as the use of immunotherapy, including donor lymphocyte infusion and second allogeneic transplant. However, it is unclear to what extent these recent developments may influence the risk factors and outcome of AML relapse after allotransplant. So in this EBMT 2020 meeting and within the EBMT Acute Leukemia Working Party, we assessed the influence of the year of relapse and relapse characteristics on the outcomes of relapse AML after allotransplant. So we analyzed the EBMT registry data of more than 8,000 adult AML patients who suffered from hematological relapse between 2000 and 2018 after allotransplant performed in first complete remission from matched sibling, unrelated, or haploidentical donors. And median follow-up for survivors was 35 months. And so to summarize the results of this study, we observed a steady increase over time in 2-year survival from relapse after transplant for young AML patients. Young patients defined as patients below 50 in relapse after transplant. So this increase was from 16% in 2000, in the initial period, up to 26% in recent years. Unfortunately, we did not observe a similar increase over time for older patients above 50 who relapse after transplant. Importantly, this improvement over time for younger patients was noted in the intermediate cytogenetic risk groups and in either FLT3 wild type or FLT3 ITD. And this improvement over time was noted both for early relapse, patient relapsing less than 6 months after allotransplant, as well as late relapse more than 6 months after transplant. And finally, very encouraging results were observed with more than 30% 2-year survival among patients who could receive a second allogeneic stem cell transplant. So in summary, we can say that in recent years, particularly for younger patients, a relapse after allotransplant for AML is not the end of the game. We have new strategies, including targeted therapy, targeting the genetic abnormalities that can be combined with different other treatment modalities, as well as the use of second allogeneic transplant. And this can allow to have a long-term survival for 25 to 30% of AML patients relapsing after allotransplant. Thank you for your attention.